Let's jump right into the Step 2 CK decision logic for pericardial and aortic vascular pathologies. For this exam, recognizing these specific clinical patterns quickly is absolutely essential. We have to sort acute chest pain immediately. If a patient presents with pleuritic pain that noticeably improves when they sit forward, you should suspect acute pericarditis. Now, if they describe an abrupt, severe, tearing pain radiating straight to their back, that's a massive red flag for an aortic dissection. And if you see a triad of hypotension, clear lungs, and jugular venous distension, that points squarely at obstructive shock. Think cardiac tamponade or massive pulmonary embolism rather than your standard cardiogenic pulmonary edema. Digging into acute pericarditis, the etiologies generally fall into a few buckets: viral or idiopathic, autoimmune diseases like lupus, uremia from severe renal failure, and post-myocardial infarction causes. Classically, these patients present with that pleuritic chest pain we just mentioned, plus a pericardial friction rub on exam. For the ECG, you are specifically looking for diffuse ST segment elevation and PR segment depression, plus an echocardiogram might show a possible effusion. Now, the next best step for treatment hinges entirely on the underlying etiology. For your standard viral or idiopathic cases, you're going to use an NSAID plus colchicine. But if a patient develops early peri-infarction pericarditis right after an MI and they need treatment for significant pain, use high-dose aspirin instead. You want to avoid standard NSAIDs to prevent a ventricular free wall rupture. For delayed Dressler syndrome, which is an autoimmune post-MI pericarditis, you actually want to avoid anticoagulation if at all possible because of the risk of a hemorrhagic pericardial effusion. And for uremic pericarditis, which by the way often lacks those classic ECG changes, you absolutely must rule out tamponade before initiating dialysis. Moving on to pericardial compression, you have to distinguish between two completely different mechanisms of restricted filling. Constrictive pericarditis is a chronic condition caused by a stiff, fibrotic ferrotic pericardium that physically limits diastolic filling. It's like the heart is trapped in a rigid box. Cardiac tamponade, on the other hand, is an acute pressure problem. Fluid rapidly accumulates in the pericardial space, and that pressure physically crushes the heart chambers, severely limiting filling. So let's look at constrictive pericarditis first. This usually stems from recurrent viral or idiopathic pericarditis, prior cardiac surgery, radiation therapy, uremia, connective tissue disease, or tuberculosis if the patient is from an endemic area. The clinical findings mimic right heart failure, fatigue, dyspnea, peripheral edema, ascites, and hepatic congestion. Exam clues are highly testable here. Listen for a pericardial knock and look for JVD with a positive Kussmaul sign and a prominent Y descent. Diagnostics will typically reveal a low-voltage ECG, pericardial calcification, biatrial enlargement, but crucially, a normal ventricular wall thickness. If the disease is symptomatic, the definitive treatment is a pericardiectomy. In contrast, cardiac tamponade causes acute obstructive shock. The classic presentation is Beck's triad: hypotension, jugular venous distension, and muffled heart sounds. Sinus tachycardia is also a major clue. And remember, because the fluid is backing up into the venous system and not the pulmonary vasculature, the lungs will be completely clear. A massive diagnostic clue for tamponade is pulsus paradoxus. This is defined as a drop in systolic blood pressure of greater than 10 millimeters of mercury during inspiration. What's happening is that increased right-sided filling during inspiration causes the interventricular septum to severely bulge toward the left ventricular cavity, which sharply decreases left ventricular preload and, consequently, stroke volume. On an ECG for tamponade, you're looking for low-voltage QRS complexes and a phenomenon called electrical alternance. This shows up as alternating amplitudes of the QRS complexes from beat to beat. It literally represents the heart swinging back and forth within a massive, fluid-filled pericardial effusion, which changes its electrical axis with every swing. From a decision-making standpoint, if a patient with suspected cardiac tamponade is hemodynamically unstable, your immediate next best step is urgent ultrasound-guided pericardiocentesis. You have to restore cardiac output, so do not delay this for advanced imaging. Now, if the patient happens to be stable but has recurrent effusions, they might require a pericardial window instead. Let's shift gears to aortic dissection. Risk factors include chronic hypertension, Marfan syndrome, connective tissue diseases, a bicuspid aortic valve, Turner syndrome, pregnancy, cocaine use, and recent aortic instrumentation. If a patient comes in with that abrupt, tearing chest pain we talked about earlier, you must start anti-impulse therapy immediately. We're talking an IV beta blocker like esmolol or labetalol right alongside pain control. This is the crucial first step before you even send them for confirmatory imaging. Once their heart rate and pressure are controlled, your imaging choice depends entirely on patient stability and their comorbidities. If they are hemodynamically stable, get a CT angiography with contrast to map out the extent of the dissection. But if the patient is unstable, has a contrast allergy, or has significant renal failure, the preferred modality shifts to a bedside transesophageal echocardiogram, or TEE. The type of dissection dictates the definitive treatment. Stanford type A dissections, which involve the ascending aorta, demand immediate emergency surgical repair. Uncomplicated type B dissections, which are confined to the descending aorta, are managed medically with strict blood pressure control. Either way, you have to monitor closely for complications caused by the dissection flap extending. This can include stroke, Horner syndrome, acute aortic regurgitation, myocardial infarction, tamponade, hemothorax, renal or mesenteric ischemia, and even paralysis. Moving further down the aorta, let's talk aneurysm disease. The screening guideline for an abdominal aortic aneurysm is highly specific and frequently tested. It is a one-time abdominal ultrasound for men aged 65 to 75 who have ever smoked. Most of these abdominal aortic aneurysms are completely asymptomatic and are located in the infrarenal aorta. Ultrasound is perfect for diagnosing and following them because it doesn't expose the patient to contrast or radiation. Long-term management is dictated by three things: the aneurysm's size, its expansion rate, and whether the patient starts developing symptoms like dull abdominal, back, or flank pain. The magic number you need to commit to memory for this exam is 5.5. Elective surgical repair is indicated for an asymptomatic abdominal aortic aneurysm once it reaches a diameter of 5.5 centimeters. However, repair is also firmly indicated for any rapidly expanding aneurysm, meaning it grows half a centimeter or more in a 6-month period, or if the aneurysm becomes symptomatic regardless of its actual size. If a patient presents with symptoms suggesting an unstable aneurysm, like severe flank pain or a palpable pulsatile mass, and they are hemodynamically stable, your next best step is a CT of the abdomen with contrast. This confirms the size and checks for imminent rupture. But if they are hemodynamically unstable, you completely bypass the CT, grab a focused bedside abdominal ultrasound to confirm, and proceed straight to emergency surgical repair. Let's wrap up with a couple of specific vascular conditions. Aortic coarctation is a thickening of the tunica media that mechanically narrows the aortic arch. This creates a really distinct clinical picture: high blood pressure and bounding pulses in the upper extremities, contrasted with low blood pressure, weak pulses, and claudication in the lower extremities. This difference is known as a radiofemoral delay. You might also spot left ventricular hypertrophy on an ECG and hear a distinct interscapular murmur on exam. Chronically, that massive pressure gradient forces the body to create collateral circulation, heavily relying on the intercostal arteries. Over time, these dilated, pulsating intercostal vessels literally wear away at the bone, producing inferior rib notching on the 3rd through 8th ribs, which you can easily spot on a chest X-ray. In neonates, severe coarctation often suddenly manifests a couple of days after birth. Why? Because that's when the ductus arteriosus naturally closes, abruptly throwing the infant into cardiogenic shock. Since their systemic circulation is entirely ductal dependent, your immediate next step is to administer prostaglandin E1. This keeps the ductus open and maintains vital perfusion until surgical repair can be performed. Finally, we have aortoiliac occlusion, better known as Leriche syndrome. This presents with a highly specific, very testable clinical triad: bilateral buttock and thigh claudication, impotence, and symmetric atrophy of the bilateral lower extremities. Keep this triad locked in your memory for test day.